Hi, I'm Jo.
Hi, I'm Philippa.
And we're the resource officers for Rotherham Foundation Trust. So it's our job to provide training to staff members in the hospital and also out in the trust. So what we're going to do today is we've just filmed a video to cover your master training that will cover you for the year.
So emergency equipment needs checking on a daily basis. So these checks should include your trolley, your defib, suction, both portable and wall mounted, and oxygen, both portable and wall mounted. Once these checks have been carried out, they need recording in your daily emergency equipment checklist. It's really important that these checks are recorded when they're done. Part of our role is auditing that these checks have happened. Some areas do really well, some not so well, and we do have to report this information back to the resource committee, and it does get disseminated throughout the trust. So these are the crash trolleys that we use in the trust. The blue ones are the adult crash trolleys. These trolleys are looked after by theatres, so you don't need to worry about any expiry dates or any of the equipment that's in there. Theatres have a list of every trolley, where it's located, and any equipment that's about to go out of date. So the checks that you need to do on a daily basis in your clinical areas are check that it's clean, it needs a damp dust on a daily basis, and also that the seals are intact. So the seals that should be present is this red and white tape that's all the way around the crash trolley, and also 2 silver tabs to close the front flap down. So if there's any problem with these seals or any issues you've got with your trolley, you just need to take it back to theatres and they will swap it for a new one. So if you decide you need your crash trolley, you're going to wheel it to your patient's side, break your seals and open the cover. Ideally, you should leave this blue cover on the trolley. If you take it off, it generally ends up on the floor and it can get in the way and it gets dirty. Under the front cover, there is a pink sheet on a clipboard. So we take part in the National Cardiac Arrest audit in this trust. So every cardiac arrest that happens in the trust will be eligible for the audit if it meets certain conditions. One of these is that the call must have gone out as a 4-2 call, and the patient must be in cardiac arrest and have required either compressions and or a shock, okay, and the patient must also be over 28 days old. If the patient meets the criteria, the team leader should fill this pink sheet in. If the team leader doesn't, anybody in theory can fill it out. The team leader usually knows the answers to the questions, but anybody can fill out what they know. If the team leader does go, if as a bare minimum you could just put the patient's details, a patient sticker on there would be great, then we can follow it up. Once it's been completed, if you pop it back under there for confidentiality, you'll get returned to theatre with your trolley and they'll send it to us in internal mail. So your trolley's laid out in order of use. So your top trolley, your top drawer is your basic airway equipment. So in here you've got a non-rebreathe mask. That will need plugging into oxygen, turning up to 15 litres. There's a little valve that you pop your finger over so that the bag can inflate, and once the bag's inflated, it's suitable for use on your patient. Your patient must be breathing for themselves for that to be used. You've also got a razor on here. If your patient's in cardiac arrest and you need to apply defib pads, and the patient's got a hairy chest, you're going to need to shave where the pads will be applied so that they can stick properly. Selection of gloves there. You've also got 2 Cadell airways. There's a green and an orange. Generally speaking, the green fits a female, the orange fits a male, but we can show you how to measure in size later if you're unsure. There's also 2 nasopharyngeal airways on the trolley. Don't worry too much about these if you're not sure how to use them, but they are there available if you do need them. Last but not least, you've got your ambu bag. So this will need plugging into oxygen again, turning up to 15 litres. This time the bag will inflate itself and it's ready for use on your patient. So we do teach a 2-person technique at the trust. One person will hold that mask on the patient's face with 2 hands, and a second person will then squeeze the bag to deliver the breath as required. You may see anaesthetist using this equipment a single person technique, but they are the experts. Everybody else should be using a 2-person technique and holding it on with both hands. The next drawer is your advanced airway equipment. So here we've got a selection of ET tubes. It's not routine and common these days for arrests to be managed with an ET tube. It's much more likely that the airway will be managed with an eye gel. So there are 2 sizes on here, a 3 and a 4, and that's more likely what you will see used. You've also got a laryngoscope in here if the patient does need intubating. available for use. So we used to have laryngoscopes that we reused. They were big heavy silver instruments that got cleaned, sent to sterile services and repackaged, but now we've gone to disposable, so we don't need to reuse them. But saying that, they do have batteries built into the handle, and these cannot be thrown just into any bin, so they do need dismantling. Usually the ODP will do that. If they do forget, if you just wrap it in paper towel, pop it on top of your trolley, and when you return it, mention it's there and they will dispose of it for you. We've got a water circuit. This says for anaesthetic use only. Don't worry too much about this, but it's there if the anaesthetist does want to use it. And you've also got a pair of heavy duty scissors. So these are for gaining access to the patient's chest, if you need to apply defib pads. They also form part of the hospital's ligature policy now. So if you do come across a person who's tried to hang themselves and you need to cut them down, you can access your heavy duty scissors on this drawer. A&E have been classed as a high risk area, so they have a special ligature cutter, but for everybody else you can access your heavy duty scissors in your crash trolley. Third drawer contains your IV access equipment, so you've got a selection of syringes, needles and cannulas in here. You've also got some spare suction equipment, so you should have suction equipment ready for use at all times in your clinical area. These are spares in case what you're using gets blocked. Okay. In the fourth drawer, you've got a selection of IV fluids. You've got Hartmann's, saline and glucose. You've also got some giving sets and a stock of posi flushers. So these are for flushing drugs into the system of a patient. Normally 10 mils is enough to flush drugs into the system, but a patient in cardiac arrest, you need to use 20 mils after every drug. So if you are injecting the drugs, make sure you use 2 of these posi flushers to make sure the drugs are in the system, and if you're passing the drugs to somebody else, make sure you pass them 2 of these and encourage them to use them both. At the bottom of your trolley, you've got a small sharp spin. So this doesn't need to go back to theatres, it can be disposed of in your clinical area as normal. You've also got a box full of your emergency drugs. So this will be sealed and it will have an expiry date on. It will all be in date because theatres know when drugs are about to expire and they will swap your drug box before this happens. Okay. So one we opened earlier. So if you do need to use it, just break your paper seal, undo your clips and open your box up. So we've got 2 rows of drugs. This is adrenaline, which is your first line drug in cardiac arrest. This is your 1 in 10,000 vial. There is a lot on here, but there's enough here for about 30 minutes of resuscitation attempts. Normally after about 20 minutes, you know whether you're going to be carrying on. Sometimes you've had a successful result, sometimes you've decided to stop. Occasionally it is appropriate to carry on. So when you get down to having 2 vials left, you've got about 8 minutes worth of CPR time to go. That's enough time to dispatch somebody to theatres to get you another drug box. Please don't pinch from adjoining areas. In this row you've got drugs that are less commonly used in an arrest situation, but they are still in the algorithm, so included in your drug box. You've got sodium bicarbonate, calcium chloride and amiodarone here. These are all pre-made. You've also got 2 boxes. You've got atropine, which is used for patients who are bradycardic and maybe peri-arrest. And you've also got a full box of adrenaline, but this is an ampule that is 1 in 1,000. These are for patients who may be suffering from anaphylaxis. If you do suspect your patient suffering from anaphylaxis, you need to put a 4-2 call out because this is a life-threatening condition and you need to start drawing up your adrenaline. Some areas that have been classed as high risk for anaphylaxis will have anaphylaxis kits available. These areas include theatres, obstetrics, CCU, X-ray and areas that give chemotherapy. If you do have an anaphylaxis kit, it's a good idea in the first instance to get your resus trolley because you will need some of the equipment on there. Start drawing up your adrenaline and use your anaphylaxis kit for your second line drugs. So once your attempt's finished, you need to make sure that your trolley is safe. Make sure there are no sharps on there and there's no contaminated equipment, with the exception possibly of your laryngoscope that you're going to wrap and pop on the top. Please don't put any used items back in the drawers, it will contaminate any unused items. You need to send somebody to theatre reception with the trolley to swap it. In ours this is easy because there's loads of people in reception. just ask them for a new trolley and they'll swap it like for like. Out of hours it's a bit trickier because if there's only one team that works in theatres, and out of hours they may be operating. So you might have to call emergency theatre on 5339 before you go. If you do forget this, don't worry, there's a sign on the door telling you what number to ring, and they will come out of theatre, swap your trolley, so your area shouldn't be without emergency equipment for more than 5 minutes at a time.
John? John, can you hear me? Can I have some help, please?
Everything alright?
Philippa, can you put a 4-2s call out, please, and bring a resus trolley? This patient's in cardiac arrest.
Put the 4-2s call out and I've got the trolley.
Are you happy to manage airway with your Dill and a bag valve mask, please? Just let me know when you're ready.
Okay, ready. 1, 2.
So we're going to do a 30-to-2 ratio now, okay? 5, 26, 27, 28, 29, 30.
1, 2.
25, 26, 27, 28, 29, 30.
1, 2.
John? John, can you hear me? Can I have some help, please?
Everything alright?
Philippa, can you put a 4-2s call out, please, and bring a resus trolley? This patient's in cardiac arrest.
Put the 4-2s call out and I've got the trolley.
Are you happy to manage airway with your Dill and a bag valve mask, please? Just let me know when you're ready.
Okay, ready. 1, 2.
So we're going to do a 30-to-2 ratio now, okay? 5, 26, 27, 28, 29, 30.
1, 2.
25, 26, 27, 28, 29, 30.
1, 2.
So next part of your resus attempt is that you're going to attach a defib onto your patient's chest, and we have got a couple of kind of defibs in the trust. So if you work in your main wards and your general wards, you'll have access to this kind of defib, which is a manual one. If you work in outpatients, clinics or at Green Oaks, you will have access to an AED, which is in the red hard case. So your defibs need checking on a daily and a weekly basis. So your daily check is to make sure you've got the black flashing hourglass in the corner and your battery power light's illuminated when it plugs into the mains. You also need to make sure that the cable is plugged into the test load so that the cable can do its self-checks. And you also need to make sure that you've got 2 sets of in-date sealed pads with your defib at all times. Your weekly check is a little bit more long-winded, but every defib will have these cards attached, and these do show you how to do your weekly check. You need to make sure that you're doing your weekly check Monday to Friday between the hours of 9 and 5, so if there is a problem with your defib, you've got the backup of clinical engineering. If you don't know how to do your weekly check, someone on your ward should be able to do it. If not, you've got your cards, or if there's any problems, you can always give me and Philippa a ring in our office and we can come down and show you how to use your defib. So if you do need to use your defib, you're going to bring it to your patient's side. Please remember that it should be plugged into the mains at all time when it's not in use, so just remember to unplug it before you run with it. And it can stay off charge because it's got a good battery power life for when it's in use. Just remember to plug it back in once your resuscitation attempt is finished. So you're going to bring that to your patient's side, open up your pads and take your pads out. You're going to turn your defibrillator straight up to 150 because that's what we shock all our patients at. Take your test load off the cable and plug your pads in. So your defib pads will look like this. So you've got 2 pads. So your first pad is going to go to the upper right of the sternum, just below the clavicle, and your second pad is going to go mid-axilla, so the centre of the pad is right in the middle of the armpit. So you're going to work round the person doing chest compressions, put your pads on so CPR isn't interrupted, and top tip is just peel your pads off one at a time. If you peel them both off at the same time, what happens is they'll just stick together and you'll have to use your second set of pads. So once your defib pads are in position, we'll pause CPR briefly, quick look at the monitor to see what the rhythm is, and then straight back to chest compressions while we decide if we're going to defibrillate the patient or not. Chest compressions do need to continue while we're charging defib. So if you're the person doing the chest compressions and you can hear the defib charging in the background, that's fine, that's meant to happen. It's just that we don't want to lose the pressure in the chest that we've built up by doing the chest compressions, by letting that drop while we're charging the defib. The team leader will make sure that you stood clear before we shock the patient, so your shock will be delivered if needs be, and then straight back to chest compressions afterwards. So we also have AEDs on site as well, so these are in more low risk areas such as clinics, outpatients and at Green Oaks. They are in a red hard case. These do have daily checks as well, so you need to make sure when you look through the little window that you've got a green flashing light. If there is a problem with your defib, that'll turn to red and it'll start beeping at you, and you can't ignore it because it's really loud. You also need to check as well that you've got 2 sets of in-date pads with your defib at all times as well. So although there might be slightly different models, these defibs work in exactly the same way as the ones that are out in the community. So the ones in the green lock cabinets on the outside of buildings. And if you do come across a patient in cardiac arrest out in the community, when you ring 999, the ambulance service will tell you where your nearest defib is, and they'll give you the combination code to be able to access it. All community defibs come with razors and scissors as well, so you can cut clothes off to expose chest, and that includes underwear, and you can also shave chest so that you get good pad placement. So we're going to do a quick demo of how to use your AED. It's really easy and anyone can use them, but we just like to show everybody so you can see how easy they are to use. So you can assume that my patient's had an assessment and someone's doing chest compressions, and I've brought the defib to the patient's side.
Remove clothes from patient's chest.
So I'd cut the clothes off, do a quick chest sweep while chest compressions are ongoing.
When patient's chest is bare, open grey plastic case and peel off white. Look carefully at the pictures on the white adhesive pad.
So you've got your
peel one white pad from the grey case.
So you've got your pad placement
Place
pictures
pad
on there
exactly
as well.
as shown.
So you're just going to pop them in the
Press
same
firmly
position.
to bare skin.
as you would your manual pads.
Stay clear of patient.
So everybody stand clear.
Analyzing heart rhythm. Stay clear of patient. Analyzing heart rhythm. Shock advised. Stay clear of patient. Press the flashing orange button now.
Quick look round, everybody clear,
Shock
shocking.
delivered. Be sure the ambulance service has been called.
And you can go straight back to
It
chest
is safe to touch the
compressions.
patient. Start CPR. For help with CPR, press the flashing blue button.
So not a lot of people will need help with CPR because we've trained you how to do it, but if you do need help, you can press that blue flashing button. Pressing that, it just tells you where to put your hands, how deep to compress the chest and how quickly you need to compress the chest, and it also
1
factors
minute,
in the
45
breaths.
seconds until analysis will resume.
So I'm going to switch this off because I have to shout over it. Obviously if it were attached to a real patient you'd leave it switched on. So what happens now is that the machine times 2 minutes, and after 2 minutes it'll reanalyse like it did in the beginning. So it may say shock advised, where it'll charge itself and you'll just need to press the shock button again, or it may say no shock advised. If it does say no shock advised, that doesn't mean your patient's not in cardiac arrest. It just means that the rhythm of the heart isn't compatible with defibrillating shock, so you're going to go back and do another 2 minutes of CPR. So your sequence of events is always going to be analysis, shock or no shock, 2 minutes of CPR, analysis, shock or no shock, and 2 minutes of CPR. And you're going to continue in that cycle until help arrives or your patient shows a sign of life. People sometimes become really worried about what is a sign of life, but don't worry, that they're really obvious. So your patient will change colour, so they'll go from a dusky blue colour and start pinking up, start moving and hopefully start breathing. If that does happen, you're just going to keep assessing ABC like you did at the beginning until help arrives. So we spoke about help and equipment that's available to you in your clinical areas, but there's also help and equipment available to you in your non-clinical areas as well. So if you do come across a patient that's unwell or in cardiac arrest in a non-clinical area, so that's places like the canteen, stairwells, corridors, down at the main entrance, you must put a 422's call out and ask for the cardiac arrest team. Switchboard will then send that message out to everyone that's on the bleep, and then we'll come to you. Members of your cardiac arrest team are your anaesthetic, reg and your ODP, and they'll take care of the patient's airway if necessary. You'll also get the medical registrar that'll act as team leader, and you'll get some junior doctors as well. Myself and Philippa will also come if we're around, but sometimes we're not always available. You'll also get the site manager, and the site manager will bring a grab bag with them, and in that grab bag there's some basic airway equipment, some oxygen and an AED. The porter will also come as well, and the porter is indispensable. They'll bring you anything that you need. They'll bring you trolleys, chairs, more oxygen, or if needs be the hover mattress. They'll also help liaise with A&E as well, because that's more likely where the patient's going to go, and they'll help assist the patient up to A&E with the assistance of a doctor. So that's if you're in the trust. If you come across a patient that's unwell in the hospital grounds, so places like the car parks, down at any of the bus stops or Green Oaks, those areas are actually 999 areas, because we need an ambulance to bring the patient safely into hospital. We know at Green Oaks you do have access to an internal phone, but we just haven't got time to get there and get the patient safely into hospital without that 999 ambulance. So those areas are 999 areas.
So when a patient's admitted, they may come in with a community DNA CPR already in place. It is the responsibility of the admitting clinician to make sure that they're still happy that this is valid and still appropriate. If it is, just needs documenting in the notes that this has been looked at. If the patient comes in without a DNA CPR and the admitting clinician feels that it is appropriate for a patient to have a DNA CPR, then they should have conversations with the patient if appropriate, and family, again if appropriate, at the earliest opportunity, so that if a patient's condition does deteriorate, then they don't undergo CPR unnecessarily. It may also be necessary, if the patient's discharged, that the DNA CPR is still valid and can be taken home with the patient.